Okay, our next speaker is going to talk to us about the surgical management of melanoma. Let's welcome Dr. Russell Berman, who is an associate professor in the Department of Surgery at Perlmutter Cancer Center.
Thank you, Rachel. So this is the difference between me and Dr. Hale. Well, Dr. Hale this morning on a rainy day was able to remember to put on sunscreen. I apparently forgot to pack my suit pants. So I was in the operating room this morning, as Dr. Hale mentioned, and at 10 to 10 when I went to go change into my suit, I realized that my pants are somewhere between my car, Bellevue, and here. So I do apologize for being in the scrubs, but that's the difference in a nutshell between me and Dr. Hale. Also, just if I could emphasize one thing, I think, as Dr. Hale mentioned multiple times, is tanning beds. I mean, this was not recognized how dangerous these are. The World Health Organization now classifies them as the same level of carcinogen as cigarettes and asbestos. So the fact that they actually still exist is remarkable to me, but if there's anything you choose to stay away from, it's indoor tanning beds. So my focus is from the surgical perspective. I'll try to keep it very practical. And obviously I'm limited. As Dr. Hale said, I took care of an extensive basal cell this morning in the operating room, which was unfortunately mistaken as a chronic wound that just wouldn't heal for over 7 years by very good teams of wound healing doctors at other institutions. And it wasn't until they changed to one of our wound healing doctors that they biopsied it. And it's a large ulcerated lesion of the lower extremity where I had to literally cut down to bone, Achilles tendon, and muscle in order to hopefully clear it. And we don't even know yet whether it's completely cleared. So although they could almost always be cured in their early state, this is what happens when even the person tried to take care of it. It just unfortunately wasn't recognized that it was a cancer. So just to outline, I'm going to try to keep this very practical. And kind of to start where Dr. Hale left off, you do not need to be a trained medical professional to kind of sound the alarm to have something checked out. If it's bleeding, if it's itching, persistently failure, just like Dr. Hale said, if you're worried about it in any way, or if there's any change, go see your physician, and even if you don't have a dermatologist, start with your primary care doctor. And as Dr. Hale mentioned, although melanoma incidence is rising, as you can see here, and precisely because for the most part of earlier detection and increased detection, the mortality levels have leveled out and in some populations are even decreasing. Precisely because we are catching them at an earlier stage, and also, thankfully, more recently, to advances in treatment for advanced disease, which were literally unimaginable, 10, 15 years ago, and Dr. Pavlik will talk about that. So let's say you're given the diagnosis of melanoma. You get called up by your dermatologist or another physician and say, gee, I'm really sorry, but the diagnosis came back as melanoma. Usually it's a dermatologist that'll tell you, but how much information you're given varies. And I usually do ask my patients when they come see me, what information were you given? And it's remarkably variable. Some dermatologists say, well, you have melanoma, go see somebody. Others will be given a lot of information, but I never take for granted that the person comes with information, because the information that you have is quite variable at that point in time. So you're told to see somebody, and who should it be? I think I'll make the case that a surgical oncologist is somebody who has additional training in cancer surgery, specifically for things such as melanomas, where it may not be the typical practice of a general surgeon's daily basis of what they see. And yes, I mean, absolutely, an informed patient is great and better. I think back in the old days when some of the physicians say, oh, it was great when the patient just said, anything you say, doc, that's what I'll do. you know what, maybe back when there weren't many options that was appropriate, but in today when there are many options, clearly a well-informed patient is better for all of us. However, you can't learn it all overnight, especially if we're just told about a diagnosis. It's hard to maintain objectivity to learn. And also, you know, people just go straight to the internet. And information on the internet can be fantastic, but it could also be disastrous and downright scary. So you have to know where to look. So the one thing that I tell the patients always to bring is their pathology report. And this is very important because not all pathology reports are, you know, made the same, and not all reads are the same. So the first thing that we want to do, and I don't expect the patient to do this, but something that I will go over with them, is that we want it to be read by a dermatopathologist, derm obviously meaning skin, and a pathologist who somebody studies, you know, the tissue of disease. And a dermatopathologist is somebody who has specialty training in skin pathology. So they don't look at a gallbladder 1 minute, a prostate the next minute, and then all of a sudden there's a rare, unusual skin pathology in front of them. They see skin pathology all day long. This is their expertise. So this is who you want to read your pathology report. And it's okay if that wasn't done originally. We'll request the slides and we'll have our skin pathologist read it, but we want it to be done by a skin pathologist. And the reason why is because sometimes the person who does a biopsy is just looking for a tissue diagnosis. Is this melanoma or is this benign? But for us to be able to treat it, we need to know subtleties. And that's something that will help determine the margins we take if it is a melanoma, and whether or not we need to look at the lymph node or node surgically. It also helps us in being able to give somebody an adequate prognosis and staging the tumor, so we could basically give people information such as, according to the statistics, what do things look like for the future, and whether or not other therapies should be considered, including clinical trials. So I cannot stress how important a biopsy, a pathology report is, and that it's done correctly. So this is, if there's one thing that you bring with you to your appointment, this is it. Now, what goes into a good pathology report? The thickness of melanoma, not necessarily the diameter, as Dr. Hale pointed out. You could have a tiny punctate lesion that's a very thick melanoma, and that's going to be very concerning. You could have a very broad lesion that's completely benign, or a very early acting melanoma. It's the thickness, how deep it penetrates into the skin, that makes a difference. So this must be commented on. Now, I show this because it scares my patients all the time. Historically, there was something called Clark's level. It was very important for decades. It was the first clue that the deeper the penetration into skin levels, the worse that melanoma would behave. Except that now we don't use it, and when they use levels like 1, 2, 3, 4, people see Clark's level 4, and they interpret that as stage 4 melanoma, which would imply that the disease has spread to other organs. So I think, quite honestly, on a pathology report, if you see anything that says level or stage with a Roman numeral after it, just ignore it, or ask us about it. But it's very confusing to patients and alarming to them. We do not use that at this point in time. Ulceration is quite simply like an ulcer. If the skin breaks down over the melanoma, it tends to act worse, and that should be at least commented on. And for those of you who took biology in high school, college, or medical school recently, you may have learned about mitotic or mitoses when a cell divides, but it would make more sense that the more rapidly a cell divides, in other words, the more mitoses that are seen in the microscope, the more aggressive this tumor may be because it's dividing more rapidly. These are all things we do want to see on a pathology report. And again, if it didn't come with your pathology report, we'll ask our pathologist to comment on it. So what is the difference between a surgical oncologist and a surgeon? Well, a surgical oncologist is a fully trained general surgeon, but we had additional fellowship training in cancer surgery. So in other words, an emphasis on cancer biology, cancer pathophysiology, and the multidisciplinary care of the cancer patient. So we understand all of the stuff that goes into the oncologic management and the principles of it, but also the cancer surgery part of things. It is not the same as a dermatologist or a dermatologic surgeon. There are overlaps in specific diseases, but they are different responsibilities with a melanoma patient. But the surgical oncologist is usually the first physician seen after you're given the diagnosis of a melanoma by a dermatologist. Now, there are 3 levels of surgical intervention I could speak about. I don't have time to do all of this, so I'll touch base on what to do with the primary melanoma that you get diagnosed by the dermatologist, and I'll talk a little bit about lymph nodes, but I'm not going to have time to talk about surgery for distant disease in other organs of the body at this point in time. So we have a melanoma. We know we have to excise more than just the biopsy that was done by the dermatologist. So what's the goal of getting rid of it, called a wide excision or a wide local excision? Well, the goal is to get rid of all of the local tumor cells while minimizing morbidity, minimizing functional impairment, because depending on where in the body this takes place, it could be over a joint, it could be on the face, it could be on a finger, it could be anywhere. So minimize disfigurement as well. And it's known as either a wide local excision or a wide excision. Now this takes us back to a little over 100 years ago when this was considered the absolute standard of care for a melanoma. Now keep in mind, there was no understanding that melanomas that were deeper or had higher mitoses or ulceration acted worse. This was, any melanoma was treated this way. So it could have been an incredibly early melanoma, and you would have basically your entire skin with the subcutaneous fat basically 2 inches all the way around 5 centimeters removed. So that's a huge amount. Almost all of these patients would need skin grafts in order for them to be closed up. And then the covering of the muscle was removed, and this was all done by taking out the local muscle and the local lymph nodes, the draining lymph nodes, which were in the area. Again, it could have been almost non-invasive melanoma, the earliest type, and this would be done, leaving huge defects in people, and this was absolute standard of care. If you violated it, if you didn't do this, you were violating the standard of care. So we've made some headway, and there have been at least 6 prospective randomized trials across the world now with thousands of patients in it, which have compared from the original 5 centimeter margin all the way down to 1 centimeter margin. And to summarize these, basically, again, we know that the thicker the melanoma, the more concerning it is, so we need a wider margin to clear all the local tumor cells. But in essence, our choices are a 1 or 2 centimeter margin, basically around 1/4 of an inch all the way around the biopsy site or the melanoma, or around just around an inch. So although these are not small, they're much better than it was 110 years ago. And here's some pictorials about it over here. This is blue dye for a sentinel node, which I'll mention after. But here is the biopsy site that you see circled here. This is a 1 centimeter margin, and this is a 2 centimeter margin, and you see it creates this kind of oval. Now you can't close an oval of skin very well, it just doesn't look good. The ends stick out like a triangle, so we make it into an ellipse or a modification of an ellipse. This looks like one of those hurricane things from the Weather Channel, so we call it the hurricane incision. And when you do that, we go down and we do take the subcutaneous fat, but this is a covering of the muscle called the fascia, and this we leave intact, unlike 100 years ago. And then you can pull these closed, and it actually looks pretty good. And this is a real-life version of those slides that I just showed. Here is the underlying muscle and the covering of the muscle, the fascia. This is full thickness of skin, including subcutaneous fat. And that's what the specimen looks like. When you pull it together with a multi-layer closure, it actually looks pretty good at the end. This is a gigantic melanoma on somebody's thigh, and you can see how big a margin we're going to have to take there. This could not close with just a simple pulling together, and it was such a big defect that a skin graft, which is incredibly thin, wasn't going to be able to sustain this person because they're very physically active in a construction job. So what we actually did was we took a pedicle of skin from higher up where it was looser, and we rotated around on its blood supply with its nerve, so that he had sensation in it also, and we were able to fill the entire gap with it. And this was like just 6 weeks later, so it looked very good in the long run. Here's a terrible place for a melanoma, smack in the middle of the cheek. There's not that many great options to hide that. And that's what it looked like in the operating room, and we get our plastic surgeons involved in these type of situations. And what they did was they did what's called a modified cervicofacial advancement flap, where they actually took it back to like a facelift incision by the ear and rotated the skin over towards that. Now this looks pretty terrible in the operating room, but even a few weeks later you could barely tell that there was an incision, and in fact most of these heal so well, you actually literally have to go up and look directly at it to see the incision even 6 months later. And finally, this was a young woman who was about to, it was like the beginning of August, and she was about to enter her first year of college, and she did use tanning beds. And she had a melanoma right here in her nose. And this is a terrible location because not only is it obviously smack in the middle of the face, but it's where the contour of the nose kind of curves in, and there's cartilage and bone that interface. So it's a terrible place for contour reconstruction. And this is what the defect looked like in the operating room. We did what's called, that's a specimen, and we did what's called a composite skin graft, where we used both skin as a graft taken from behind the ear, as well as a cartilage graft from the ear, from a place that she didn't need it in the ear. And when she came home for winter break, you could barely even tell that she had surgery. So when done correctly with the correct multidisciplinary team, the outcome could be outstanding even in advanced melanomas in bad places. Now let's talk a little bit about lymph node surgery for a few minutes. So let's go back historically, 20, 30 years ago. If you had big palpable nodes, which meant that there was melanoma in the nodes, well then you kind of had no choice. You had what's called a therapeutic lymph node dissection, where you took out the lymph nodes in that entire basin, and here it's the axilla. If you didn't have nodes that were concerning, there was really two options. One is what was called an elective lymph node dissection. In other words, take out all the lymph nodes anyway and see if you found any positive nodes, or just observe them and do a clinical exam. So what was the problem with this was, for those that you just took out all the nodes anyway, only 20% of those patients had positive nodes on the pathology report, and you left them with a 20 to 30% risk of permanent swelling of their arm or their leg, which is very, very life-altering. So that didn't seem too satisfying. On the other hand, observation, you kind of just waited around to see if they'd recur, and that wasn't satisfying either. Also, though, with the elective lymph node dissection, because 80% never developed nodes, you did these very morbid operations on people, and you couldn't prove that it extended their survival. So so why don't we just go ahead and do these elective lymph node dissections? As I said, the risk of lymphedema or permanent swelling is up to 30% in the extremities, and there's other damages that could take place as well. So you don't want to just do these without a reason. It's a very significant operation. So along came what's called the Sentinel lymph node biopsy in the early 90s. Basically, it's a low morbidity alternative to doing that full elective lymph node dissection for patients who didn't have palpable nodal disease in melanomas. And basically the premise is that a melanoma will spread via specific lymphatic channels to a node or nodes before reaching other lymph nodes in that basin, and that you can go ahead and trace these. And these were proven to be a safe and very reproducible way of finding the most likely node or nodes that melanoma will go to within a lymph node basin. And this just shows a pictorial of it. Here's the primary tumor. If you inject dye here, It's on the trunk, so it could go to multiple places. There's a lymph node in the groin it goes to. There's 2 lymph nodes in the armpit it could go to. And it'll go to those before going to other lymph nodes. So if you take out just these selective nodes and submit that to a very careful analysis in pathology, you'll be able to determine the need to go ahead and do all the rest of the nodes removed, or whether you can just observe from there. In real life, this is what the lymph node actually looks like. When it looks really pretty, I gotta tell you, this is a very pretty picture. It doesn't always look this nice. But you can see this lymphatic channel that has a blue dye in it, and the blue lymph node. We also use radioactivity, which we use a handheld like Geiger counter, in order to double make sure that we found the correct lymph node or nodes that drain that area of melanoma. So this sounds great. We remove 1 or 2 lymph nodes. The risk of permanent swelling is down to around 3-4% as opposed to 20 to 30%. And it's a very sensitive way to find whether there's disease. So who should we do this on? Well, once again, it goes back to the thickness, as I mentioned a few times. If you have a thick melanoma, meaning greater than 4 millimeters thick, there's around a 35% chance that you'll have at least 1 lymph node involved. But when it gets down to less than 1 millimeter, it's a less than 5% risk. And I just mentioned there's around a 5% risk of having swelling. So when your risk of the surgery is greater than the risk of finding positive nodes, you don't want to do it. So in my practice, what do I do? For anybody with a node, with a melanoma greater than 1 millimeter thick, I do a sentinel node, or I offer a sentinel node. That's pretty standard practice. If it's less than 1 millimeter thick, this will become pretty standard within the next year when the new staging system takes place. But my practice now is that if it's between 0.8 millimeters thick and 1, the risk is a little above 5%. So I do offer it when it hits 0.8 millimeters thick. In general, if it's less than 0.8, I do not offer it unless there's a large number of mitoses, or if it's ulcerated, but it's very rare that lesions that thin actually have ulceration or a large number of mitoses. So this is kind of my practice summarized. Now, with many years and a few studies down the road, what is it that we know about sentinel node biopsy? It sounds great in theory, but is this really something that we should be doing? And if you get a positive node, do you have to go and remove all the rest of the lymph nodes in that area, thus now creating a situation where you can have a 20-30% risk of swelling down the road? So what do we know about it? We know that it does allow us to selectively determine who probably benefits from a full lymph node dissection. It is the most accurate staging tool that we have for the lymph nodes. It is certainly less invasive than the traditional lymph node dissection. It is the most significant prognostic factor for disease-free and disease-specific survival for patients without known metastasis. It certainly helps us determine who should have a clinical trial, for example, for adjuvant therapies that Dr. Pavic will mention. But does it improve survival? Does this mean that if you have this done and it's positive, will you live longer by having this done? And the answer is we're still not 100% sure. We know that there are subgroups in what was called the MSLT1, or the first major worldwide trial for this, that did have enhanced melanoma-specific survival. But if you look at the group as a whole, again, because 80% of patients will have negative sentinel nodes, the whole group as a whole did not have an overall survival benefit. The MSLT2, which is a study which says, okay, you have a positive node, should we remove all the rest of the lymph nodes now or just watch it? The results of that will be out very shortly. It's in review right now. These are the first results. And the answer is we don't know exactly what the first results will show or what the final results will show. By this time next year, I should have updated information. So this is the current state of how we treat the primary and the nodes in melanoma. In terms of follow-up, it kind of depends on how thick the melanoma is and whether or not your nodes are positive or not. And each physician that you'll see will have a different focus. At minimum, you need to follow up with your dermatologist, and I would say lifelong follow-up with your dermatologist. as well as your surgeon for at least, I do at least 5 years and possibly longer depending on the thickness and the stage of the melanoma. Now it's important to remember that your dermatologist does not replace your surgeon, so if your surgeon says, please see me in 3 months, and you see your dermatologist in 3 months, please see the surgeon as well, because we do have different focuses. And certainly, your surgeon doesn't replace your dermatologist. You do not want me doing your skin screening, I promise you. So those are the minimum of 2 people that you will see in follow-up, and you very well may have a medical oncologist depending on the stage. And neither the surgeon or the dermatologist replaces the medical oncologist. So I like to think that cancer is truly the paradigm of multidisciplinary care in medicine, and I think melanoma is truly the best example within that. You have the dermatologist who's basically looking at all the skin surfaces, but will also follow up with somebody who had melanoma to make sure they don't have a new melanoma, and most of the time when you have a good dermatologist to look at the primary site of the original melanoma and make sure it hasn't come back. You have the surgical oncologist who's looking at the primary site, making sure that that doesn't come back and treating that, as well as the lymph nodes and also potentially the rest of the organs. And you have the medical oncologist who's basically in charge of the whole body. So there's tremendous overlap, and that doesn't even include many other disciplines, which I didn't put up here. So I do have a couple of questions here. I'm not sure how to trigger the maybe I just hit it, but question 1 is a surgical oncologist is A, a pathologist with an expertise in skin biopsies, B, a pathologist who reads fine needle biopsies, C, a surgeon who specializes in facial plastic surgery, or D, a surgeon with expertise in cancer care. Should I hit the button? Ah, there we go. And I'll only do this for like 10 seconds or 15 seconds, or when Dr. Pavlik tells me to stop. All right, 1 more second. Yeah, well, good. Most of you agree with me on that, so I would agree. It's a surgeon with an expertise in cancer care. Question 2, which of the following is not a factor that determines the outcome for melanoma? 1, the thickness of the melanoma in terms of millimeters. 2, how long the melanoma has been present for. C, a positive sentinel node, or D, ulceration of the skin over the melanoma. Rachel, I don't see you choosing an answer. All right. Ah, interesting. So the real answer is how long the melanoma has been present for. I mean, if it means that it's grown to a deeper extent or a spread, then yes, but it in and of itself is not a direct factor. Positive sentinel node, as I mentioned, is actually the most important determinant of survival in somebody who does not already have metastatic disease. So that's a bit of a trick question. And the last one, which I think is not as tricky, a less invasive technique to test whether a melanoma is present in the lymph nodes is called A, a radical lymph node dissection, B, a sentinel lymph node biopsy, C, the Dr. Elizabeth Hale nodal laser ablator, or D, the Dr. Anna Pavlik node crusher. Notice I used the laser ablator versus a crusher. That was intentional. All right, well, good. I see 5% shows the Dr. Hale laser ablator. Excellent. It's a new patent for you. Correct, the sentinel lymph node biopsy. So just to end, as I mentioned, it really is the paradigm of multidisciplinary care. There's tremendous overlap between the disciplines here, including radiation oncology, et cetera. I'd be glad to take any questions after, but thank you very much.